Good morning, sir. Emeritus Chairperson, sir. Honorable and distinguished faculty of the management. We also welcome the overseas scholars, and this is the flagship program of Mahatma Gandhi Hospital. We have this every Wednesday where all the departments come together and then present one case. The initial part is a presentation about the department and followed by a case which is discussed by all disciplines. So today we are going to talk about a case of breast cancer. At the outset, let me ask the audience a question. How many of us know any person with breast cancer in our neighborhood, in our family, or in our friends? More than 75%, almost 80 to 90% of the people know that there is a person of breast cancer. So it is such a common problem. Previously, it was said that in females, cancer cervix was the commonest in India, but now breast cancer has surpassed cancer cervix, and 1 out of every 8 female in the lifetime is going to develop breast cancer. This is quite an alarming thing, but the good thing is that it can be detected very early, and if detected early, there is almost absolute cure. But along with the long survivorship comes problems of associated problems of radiation or surgery. One of the common problems is lymphedema after axillary dissection. Sometimes you can even notice these people in when you go for social gatherings, they come with edema on the arm. The only treatment is prevention. And we tell every patient that after surgery, they have to have precautions like keep the arm elevated, not to drop blood on this side, not to take BP on that side, not to wear tight clothing. But then we must remember, every year the arm circumference increases by 10 millimeter. 10 millimeter is nothing, 1 centimeter circumference, but these people survive lifelong. And in 10 years, you can imagine 10 centimeters of lymphedema, which needs to be prevented. And one of the novel techniques which has come up, we are going to discuss that. And to give an overview of the department, I would request Dr. Dinesh, Professor Surgical Oncology, to give an overview of the department. Thank
you. Good morning, sir. Thank you, sir, for a brief description of our presentation. Good morning, respected dignitaries, senior faculty members, my colleagues, and dear students. So, this is our history of Mahatma Gandhi Medical College, and Surgical Oncology Department started as a twig in 2016. And with the help of senior faculty members and with this much of good infrastructure in our institute, we are getting good number of cases and doing good work in this institute. So this is our faculty. We have 6 faculty members at present in our department. Raj Govind sir is the head of the department. He is trained in Tata Memorial Hospital, and he started Surgical Oncology Department first time in Rajasthan in SMS Medical College and later on in our institute. Me, Dr. Dinesh Yadav, I am trained in GCRI, Ahmedabad. Dr. Nitin Kupteda sir, he is trained in Adyar and he is the first time CS Surgical Oncologist of Rajasthan. Dr. Rahul Gupta is DNB from RGCI, and recently he had got fellowship in Advanced Robotic Surgery. Dr. Rahul Khubchandani, he had joined 6 months back and he is passed on from AIMS Patna. Dr. Naina Agarwal is new addition in our department, sir, and that side. Sir, Dr. Naina, and she is assistant professor in our department. She is passed out of SMS, student of sir, and she is doing regular screening work and awareness work in Jaipur. So regarding our ex-faculty, initially department headed by Dr. Nutan Kumar Shukla sir. He was head of the department in AIMS and later on shifted to our institute. Dr. Sanjay Sharma, he was professor in our department till January. Dr. Abhishek Parikh, he was the first person who has started this department in 2016 and he remained for 1.5 years. Dr. Gaurav Goyal, Dr. Saurabh and Dr. Anand Mohan contributed in our department. So till now we have 9 alumni from our institute, MCH alumni, and they are, you can see they are from north to east, west, and from all sides you can see from north to south and from west to east. We have 9 MCH residents who had passed from our institute. At present, we have 6 residents, sir. Final year, Dr. Tanuj, Dr. Gyanendra, and Dr. Prekshit, who will present today's case. And second year are Dr. Prayas, Dr. Saif, and Dr. Vikhyat. So this is our extended family. Medical Oncology Department, that is headed by our director, Dr. Hemant Malhotra sir, Radiation Oncology, Oncopathology, and Medical Genetics, Onco-Anesthesia, Nuclear Medicine, and our plastic surgery team. Recently, Dr. Umesh Bansal has joined our plastic surgery department and taking care of our all flaps and other things. So in our department, work is our worship and we enjoy. You can see in this picture, all departments are there and they are enjoying with each other. So with this work, we are also doing our academic activities, that is in the form of total publications 151. In last 5 years, we had done 104 conferences and seminars, symposia are attended 250. So the main focus is on the intensive academic sessions that is done on every Friday and Saturday. So it is in the form of ward rounds, nurses rounds, case presentation, thesis presentation, logbook. And on specifically on Sunday, we have a skill development class or digital platform from 5:30 to 6:30. That is taken by Raj Govind sir. So this is some pictures of our residents who had made some skill development pictures, and you can see the beautiful pictures and with a good anatomy and good pictorial presentations. These are our achievements in different conferences, different social gatherings and different awareness programs. So regarding departmental stats, we had started from approximately 110 cases in a year to 20,000 cases at present in OPD annually. So this is our IPD from 170 cases to 2,000 cases at present. So surgical load in our department is gradually increasing from 113 to 1,600 cases. In 2025, it's slightly decreased because we are sharing our OT with a liver transplant team and robotic surgery. So it's basically our institute's gain because we are having 48 or 49 cases in last year liver transplantation. So that is also benefiting our department. So this is our busy OPD, oncology OPD. You can see huge numbers in our OPDs. This is our working place, minor OT, our ward and different rooms. This is our state-of-the-art OT. We have at present 4 OTs. 2 are on the second floor and 2 are on the third floor. Regularly in our department and in oncology department under the supervision of Hemant Malhotra sir and Raj Govind sir, this is multidisciplinary tumor board is regularly conducted 2 times in a week and approximately 20 to 25 cases are discussed in tumor boards. This is our technology transfer programs. Regularly orations and renowned faculty visits are in our institutes. We are continuously updating on skills, and OncoSurge is a dedicated program that is run by Tata Memorial Hospital, and since last 4 years it is relayed in our department. There are different patient support groups and rehabilitation activities in the form of Cancer Survivors Day, World No Tobacco Day, Stomach Clinic, Oral Oncology and Prostho Clinics. Public education and awareness advocacy is regularly conducting, and with the joining of Dr. Naina, we are continuing in that thing. She recently had 2 seminars on females, specifically in at Center of Excellence in SBI and some other specialties. These are educational grants and fellowships provided to our residents. So, with work, there are some stress also. And for de-stressing, we are regularly going with our residents and staff to different places. And this is our professional education. We are regularly continuing on that in the form of first and second Rajasthan Oncology Conclave. These are orientation programs for residents. When they join, we regularly orient them regarding hospital orientation and regarding treatment and hospital-related facilities orientation. This is our interstate MCS and DNV mock examination. This is our flagship program, and this year it was 9th mock examination, and this is conducted by Rajgovind sir and Nitin Kuteta sir. So these are some pictures of mock examination. So these are our 3 MCS surgical oncology batches: first batch, second batch, and third batch. This year, third batch was continued. These are some pictures we are treating from top to toe, and you can see good clinical pictures we are getting. And on right side, we are having breast oncology treatments, head and neck oncology. And future is in the form of robotic surgery, and we are going with good amount of cases in our department. And we are thankful to our management. They have provided this state-of-the-art robotic system in our department. Now I invite Dr. Prekshit.
Good morning, respected dignitaries, my senior professors and my dear colleagues. So today we have a case of 68-year-old lady with breast lump. I'll take a minute to explain the title that we've put. So like Isaac Newton once said, if I have seen further, it is by standing on the shoulders of the giants. So we've already come from cure of breast cancer to getting down to breast conservation surgeries and giving a form to the breast. And today we're going to be dealing with the functional part of the patient as well. So I am Dr. Prekshit, third year surgical oncology resident. I'll be taking the case forward. So we had a 68 years married female who was a homemaker. She presented to us in January of 2026, 4 months back with complaints of right breast lumps since a month. She was apparently asymptomatic a month ago. She then noticed a lump in her right breast, which was in the upper outer region. Insidious in onset, which was slowly increasing in size. It was painless and there was no nipple discharge, retraction or any overlying skin changes. There was no history of any recent onset fever, chest, abdominal pain or vomiting, no cough or dyspnea, no jaundice, hematemesis or hemoptysis, no bone or back pain, no headache or vision changes. There was no significant weight loss, and there was no history of any trauma or infections in the past. She was hypertensive since 2 years, which was well controlled on medications, and there was no other history of any comorbidity. There were no previous surgical history and no history of similar complaints in the past. So there was no history of alcohol consumption or tobacco chewing or smoking. She was a vegetarian by diet, had a normal bowel bladder and a normal sleep cycle, and she was not known allergic to any drug or food. There was no significant family history. So she reached menarche at the age of 13 years. She had regular cycles and attained menopause at the age of 58 years. She was P2L2 and delivered her first child at the age of 26 years. She did breastfeed her children for a minimum of 6 months. There was no use of oral contraceptive pills or hormone replacement therapy. For the audience, the history of breastfeeding has a protective effect on development of breast cancer. Certain evidence suggests that a minimum duration of 6 months is protective, and some of them do suggest that even 1 year, the longer the duration of breastfeeding, the more protective effect it will have.
I will also like to suggest and request all the surgical residents that they should take a good history, good obstetrics and menstrual history, gynecological history, because infertility is nowadays a big problem, and the patients are given right and left ovulation induction agents, and they go many IVF cycles, and you can see advertisement in the newspapers. Lot of IVF centers has cropped up in the country, and these misuse or overuse of these drugs may lead to the
Breast cancer.
breast cancer or ovarian cancers and other cancers also. But that is important. So do not forget to take the history of infertility. Like she was, at what age she was married? She has a first child at 26 years. So what age she was married? All right, getting my point.
Yes.
Suppose this child was delivered after 5 years of infertility, 5 years of married life. That carries a meaning whether she has undergone any infertility treatment. So that is important in the current context.
And the use of OCs in the younger age in our country is also
that is also increasing. Lot of young female, they use oral contraceptives, pills. That again is very, very important thing.
So moving forward, to summarize, we had 68 years post-menopausal female who presented to us with a progressive painless right lump of a 1-month duration with no other contributory history. At this juncture, I would like to ask the audience, what do you think would be the probable possibilities in the patient? Can somebody take this up from general surgery or anybody in the audience? Yeah, please.
The benign causes, it can be a painful cause or a painless cause. So in painful, we can have the breast abscess and some of the fibrocystic changes in the breast. And in the painless benign causes, it can be fibroadenoma. The patient can have Pillows tumor, and the patient can have accessory breast.
Doctor, you have to be very specific. It was already mentioned in the history. Have you heard the history of the patient? So it was painless to start. No? So why are you going for painful? You be specific in answering.
So breast lump, like he said, could be malignant or benign. Malignant can be very commonly invasive breast cancers. And for benign, we have either painless lumps or painful lumps. So after this, we conducted a general physical examination. The patient was of an ECOG status 1 with a grossly normal general physical examination. We continued a loco-regional examination. We started with inspection. She had a 34C breast cup size with a regnoltosis of grade 2. The right breast showed visible asymmetry due to the prominent swelling in the upper outer quadrant as compared to the left. We can, as shown in the diagram. A nipple retraction was noted, no visible ulceration, discharges from the nipple, and there was no other overlying skin changes or superficial dilated veins. So we conducted a palpation. There was no raised local temperature. We found a lump in the right breast in the upper outer quadrant at 9 to 11 o'clock position, which was 3 centimeters from the nipple areolar complex and sized about 4.5 to 3 centimeters. It was round to oval in shape with irregular surface and margins. It was non-tender, hard in consistency. Nipple retraction was confirmed and areola was found not involved. It was not fixed to the overlying skin, underlying pectoralis major muscle or chest wall. You can see it in the diagram. Continuing with the examination, the right regional axillary lymph nodes were palpated. We found a single 2 by 2 centimeter hard, mobile, non-tender node at the right level 1 constituting the anterior pectoral group, and we did not find any lymphadenopathy at the right supraclavicular region. Examination of the opposite breast and axilla were unremarkable. We conducted a systemic examination head to toe, which was grossly normal. So to summarize, at this juncture, we had 68 years postmenopausal female presented to us with a progressive painless right breast lump of a 1-month duration with no other contributory history. And on examination, we found a hard irregular lump in the upper outer quadrant of the right breast with no overlying skin changes and ipsilateral mobile axillary lymphadenopathy. So the probable diagnosis, I think it's quite evident. The age of the patient, 68 years, progressive painless lump, hard in consistency. We found nipple retraction and we did get axillary lymphadenopathy, all pointing towards a malignant diagnosis. So after this, we moved on to the workup of the patient. We requested for initial blood biochemistry, which was unremarkable. As a routine, we did get an X-ray and ultrasound whole abdomen, which were also unremarkable. So for a breast lump, we conducted the standard triple assessment. The clinical examination pointed us towards a malignant lump. So we wanted to evaluate, and we subjected the patient for an imaging. The imaging was done in the form of a bilateral X-ray sonomammogram, which showed the right breast lump had an irregular hyperdense spiculated mass lesion, which sized around 4.7 to 3.8 centimeters, constituting of BI-RADS category 5 lesion, and the left breast was BI-RADS category 1. So we continued with the triple assessment. We completed the third pillar of it. We subjected the patient to a core cut biopsy, which showed an invasive ductal carcinoma, not otherwise specified, of grade 2. We did a routine immunohistochemistry panel, which showed ER and PR positivity, which was strongly positive. HER2 was negative with a score of 0 and a Ki67 of 5 to 10% of low.
For the audience benefit, please explain HER2.
So,
full form.
So HER2 is human epidermal receptor 2. It's a receptor on the epidermis, which is involved in the tyrosine kinase pathway, and overstimulation of this leads to, or overexpression of this leads to, increased cellular proliferation. So that came out to be negative for us, which showed a good prognosis in tumors generally. So next step was to do a staging workup. The staging workup consisted of CECT thorax, abdomen or pelvis with a bone scan, or we could have done a PET-CT whole body. For this patient, we conducted a PET-CT, for which I would like to call upon Dr. Sahil Kalavadia to discuss.
Thank you, Dr. Prekshit, and good morning, dignitaries, faculties, and my dear colleagues. So this patient was referred to us for the baseline whole body FDG PET-CT scan, and this is the MIP, or the maximum intensity projection image of the PET scan of the patient, which is showing normal physiological uptake in the brain parenchyma, myocardium, liver, bowel loops, as well as in the urinary bladder. Along with that, we can clearly see there is an abnormal concentration of the radiotracer in the right chest wall. Now coming on to the three different sections of the fused CT and PET images, as well as the CT images on the lower side. Firstly, in the coronal section on the left side, we can see there is an FDG-avid heterogeneously enhancing soft tissue density lesion in the upper outer quadrant of the right breast parenchyma. And in the axial section, along with that lesion, we can see there are few low-grade FDG-avid discrete lymph nodes at the level 1 axillary region. And the same was correlated on the sagittal section as well, the lesion as well as the few discrete lymph nodes in the level 1 axillary regions. Now to summarize the findings, there was an FDG-avid lesion measuring approximately 4.5 by 4.0 by 4.8 centimeter with an SU max of 18.8 in upper outer quadrant of the right breast parenchyma, likely to be the primary neoplastic disease, as well as there were low-grade FDG-avid few axillary lymph nodes, out of which the largest lymph node was measuring approximately 1.5 by 1.5 centimeter with an SU max of 2.2. And other than that, there were no other FDG-avid lesions to suggest any distant metastasis. Now I would like to call back Dr. Prekshit to take the case forward.
Thank you, Dr. Sahil. So continuing further, we came to a final diagnosis of a 68 years postmenopausal lady who was hypertensive with the ECOG status of 1, diagnosed with invasive carcinoma right breast of invasive ductal carcinoma not otherwise specified in grade 2, with an ER/PR positive, HER2 negative and a Ki67 of 5 to 10%. We staged it to CT2 N1M0 amounting to stage 1 from the AJCC 8th edition. Since the tumor was more than 20 mm and less than equal to 50 mm, it falls under the stage T2. Since we found an ipsilateral level 1 movable lymph node, it amounts to stage N1, and no distant metastasis gives us M0. This falls under a T2M1, falls under the stage 1B prognostic staging of the 8th AJCC. So next step was to take the patient up at the multidisciplinary tumor board meeting, and the board unanimously decided to go up for an upfront surgery in the form of a modified radical mastectomy or a breast conservation surgery followed by a pathological stage-based adjuvant systemic therapy.
So, Prekshit, can you elaborate on that? Why did we choose for upfront surgery and why not for some neoadjuvant treatment?
Sir, so for the audience, if we have a luminal A tumor that falls under the...
For a non-oncology audience, explain to them.
So we divide the breast tumors into 4 luminal categories. First is luminal A, then luminal B, then we have an HER2 enriched, and the 4th one is a negative. So the IHC markers that we saw, ER, PR and HER2 new, and along with Ki-67 index, we divide these tumors into these 4. So for patients who are ER, PR positive and HER2 negative, they generally fall under luminal A, who have a low proliferative Ki-67 index. Since these tumors have a low propensity to metastasize, and it is primarily a local disease rather than a distant disease, the primary target is to remove the disease and then follow it up with an adjuvant systemic therapy. But if the patient, there are indications when we do neoadjuvant chemotherapy in such candidates, when the tumor size is bigger than the breast volume and the patient is a candidate for a breast conservation surgery, or if an ER/PR tumor is locally advanced, even in those circumstances, we go forward with neoadjuvant chemotherapy to downsize the tumor. So since the tumor, so we formulated a plan of, we explained the options to the patient, and after getting a consent, the patient consented for a right mastectomy with an axillary lymph node dissection, and she opted for no immediate reconstruction.
For the audience, tell us the difference between a classical radical mastectomy versus modified radical mastectomy.
Yes. So the classical radical mastectomy involves the difference between both of them. The Halsted radical mastectomy involved removal of the pectoralis, so the breast tissue with the nipple areolar complex and the skin. Along with, they used to remove the pectoralis major and the minor muscle, and nodal dissection involved level 1, level 2, level 3.
One more muscle, tell us.
Scalene,
anterior serratus.
Anterior serratus. Along with level 1, 2, 3 internal mammary nodes and also supraclavicular nodes. So let's go back to where it all started. The Halsted radical mastectomy. Like sir mentioned, it involved removal of en bloc, removal of the entire breast, pectoral muscles and all axillary lymph nodes, because they believed in this, what was known as the centrifugal spread theory. They believed wider resection led to better cure, and the eminent results were chest wall disfigurement, the disabling arm lymphedema that ranged up to 50 to 60%, and marked shoulder weakness, and they accepted all of these as inevitable. So this was the procedure they used to do. But we've evolved. We've come from Halstedian mastectomies to modified radical mastectomies today with the era of breast conservation surgeries. But the problem still remains, and the problem being lymphedema right here. So the burden of the disease, the problem is 20 to 40% of risk with ALND today. We've come down to 5 to 10% in patients who can be offered a sentinel lymph node biopsies. The peak onset is long lasting. It stands somewhere between 2 to 5 years, and it is one of the most burdensome long-term complications. And since the breast cancer treatment has become so effective, we are seeing more and more long-term survivors and these long-term complications today. Once established, it is chronic, progressive, and it's largely irreversible. The key risk factors being extent of nodal dissection, the extent of initial disease, the need for adjuvant radiotherapy, obesity, localized infection, and cellulitis. At this juncture, I'd like to mention all of these are risk factors, and our patients currently in the Indian subcontinent present with at least one of those risk factors. So the components of breast surgery today that we offer at our center proudly are, to address the primary lesion, we are doing a breast conservation surgery routinely. We are doing a skin and nipple sparing mastectomies, and we are doing a radical mastectomy as a standard. To address the nodal disease, we are doing a sentinel lymph node biopsy, a targeted axillary dissection.
Can you explain to the audience what do you mean by sentinel?
So sentinel means the first draining lymph node. I don't know how many of you have seen Transformers, but the first person who takes care of everything beyond them is who sentinel is. So the lymph node that drains the first from the
How
breast.
the word derived sentinel. This is Italian word, just to tell you. Sentinel, who is guarding first. What you are saying is right. It is the Italian word and later taken by the Latin. Alright? Thank you.
So we are doing a sentinel lymph node biopsy. We are aiming towards going to targeted axillary dissections, and ALND remains the standard. For reconstruction, we are doing an immediate and delayed, a partial breast, a whole breast reconstruction, and an autologous and implant-based reconstruction. But today we are going to be discussing about the lymphatic management that stands as the fourth pillar of the breast surgery today. We can do it in the form of reverse nodal mapping and prophylactic lymphovascular anastomosis. We can do it in the form of vascularized lymph node transfers and definitely pneumatic compression devices. So after discussing these options with the patient, we finally came down to a final plan of doing a right mastectomy with an axillary lymph nodal dissection. The patient opted for no reconstruction and for reverse lymph nodal mapping and prophylactic lymphaticovenous anastomosis. We took the plastic surgery consultation for the same. A pre-anesthetic evaluation was done. Patient and the family were counseled, and a written informed consent was gathered. Now I'd like to call upon Dr. Kanika Pradhan to discuss about the anesthetic management.
Good morning, respected professors and my colleagues. Here I am representing a case of 68-year-old female who came to the pre-anesthetic clinic. She is diagnosed case of carcinoma right breast with invasive ductal carcinoma grade 2. She was planned for right mastectomy with axillary lymph nodal dissection and reverse lymph nodal mapping and prophylactic lymphaticovascular anastomosis. On preoperative evaluation, her history was confirmed. She was vitally stable, pulse 79 per minute, blood pressure 128/88 millimeters of mercury, respiratory rate 14 breaths per minute, oxygen saturation 98% on room air. Regarding comorbidities, she was hypertensive since 2 years but well controlled. Her functional status was within normal range, metabolic equivalent of task more than 4. Cardiac assessment was done. 2D echocardiography showed left ventricular ejection fraction 60% with grade 1 LV diastolic dysfunction. Airway assessment revealed Malampati grade 2, suggesting no anticipated difficult airway. All routine blood investigations were within normal remit. So, she overall falls into American Society of Anesthesiologists grading 2. General anesthesia with endotracheal intubation was planned. The main thing which we kept in mind, IV cannula and BP cuff was placed on contralateral arm to preserve the lymphatics of the operative side. Patient was positioned with supine with arm abduction for good surgical access. Brachial plexus protection was taken into consideration. During modified radical mastectomy and axillary lymph node dissection, our main aim was to maintain normotension to ensure distal tissue perfusion. During microscopic lymphaticovenous anastomosis, our hemodynamic target was maintaining mean arterial pressure between the range of 65 to 70 millimeters of mercury. Temperature regulation was also maintained with target temperature 36.5 to 37 degrees Celsius. Multimodal analgesia was given with IV opioids, NSAIDs and paracetamol to facilitate rapid, comfortable recovery without any signs of respiratory depression and nausea. Patient was extubated after meeting standard extubation criteria and shifted to recovery. Post-extubation, she maintained adequate spontaneous respiration with stable vitals and no signs of respiratory distress. I would like to call upon Dr. Prekshit sir to take the case forward. Thank you.
Thank you, Kanika. So after this, so this was the surface marking and incision for the breast. We can see the anterior axillary fold right here, the posterior axillary fold, the inframammary fold and the clavicle in the sternum. We chose a modified Oz incision because the tumor lied in the upper outer quadrant. Then we started with the procedure. So the first step involves taking the incision. We took a 15-number blade. The next step incorporated raising of the flaps between the subcutaneous plane and the mammary tissue. We first raised the superior flap, and now after that we raise the inferior flap as shown in the video. We constantly keep the traction on the breast, and we keep maintaining hemostasis. We mark the whole parenchyma over the pectoralis major muscle, which you can see. The next step is to ligate the perforator vessels coming from the intercostal branches, and then after ligating, we reflect the breast tissue along with the pectoral fascia. So that's the reflected breast with pectoral fascia. We can see the pectoralis major muscle retracted under the retractors. That's the pectoralis minor muscle, and the serratus anterior muscle lying at the lateral chest wall. The superior limit of the dissection was the axillary vein that can be seen right here. After this, the removal of the breast tissue and axillary lymph nodes, we defined the major neurovascular bundles during the dissection. We can see the subscapularis muscle marking the posterior border of the axilla, the latissimus dorsi at the lateral end, the first neurovascular bundle containing the thoracodorsal nerve that supplies the latissimus dorsi, and the lateral thoracic neurovascular pedicle that contains the long thoracic nerve supplying the serratus anterior, and that's the intercostobrachial nerve. So this marks the division between the axillary level 1 and level 2 tissue. That's the area of axillary level 1. That's the area of axillary level 2 tissue. After this, we retract you can see the pectoralis minor muscle. We retract it laterally, and we dissect out the level 3 tissue medial to the pectoralis minor. Once the specimen and the nodal tissue is out, we can see the area of the upper limb lymphatics coming on the lateral chain. The last step is to identify the upper limb lymphatic channel that comes, which is double clipped. So after completion of the procedure, we can see right here, the lymphatic is double clipped. So once we are done with the modified radical mastectomy, the next step is to go forward with the reverse lymph nodal mapping. We take the tracer that we use is indocyanine in green. The patient continues to be in supine position with arm abducted by the side. We prepare the 25 milligrams, we dilute it in 10 ml and inject 1 ml of it in all second, third and fourth interdigital clefts as shown in the diagram. We take the next step is to identify the green channel. We use the infrared camera. I'd like to thank the management for providing us with these facilities today that we are able to do lymphatic mappings and sentinel and lymph node biopsies. We can see the green channel that gets lighted up post the ICG, and that's the green channel, the reverse mapped channel coming from the upper limb lymphatics. So after this, we move forward for the lymphatic or venous anastomosis. I am grateful to the plastic surgery department who've been working tirelessly with us. They've given this another armor in our armamentarium to offer breast cancer patients. We use a surgical microscope for that. The system that we have is a Leica Provido, has a maximum magnification of about 40x, but the anastomosis that we generally do is at 30x. So as seen in the figure, so this is the breast tissue with the lymphatics that we've cut out. These are the lymphatics coming from the upper limb. So we anastomose these lymphatic channels to the venous tributaries right here. So that's a video running at about 2x speed at 30x zoom. We can see the lymphatic channel here, and we can see the venous channel here. The suture that we use is an 11-0. You can't see it with naked eyes. You can't even feel the suture, but you can just feel the needle of it. We take 4 to 5 interrupted sutures all around the circumference, and it's the size of the anastomosis stands around 0.3 to 0.8 mm. So after completion of this anastomosis, this is what the final picture looks like. We have a lateral thoracic vein that's anastomosed. That's the blue lateral thoracic vein that is anastomosed to the upper limb lymphatic, and the lymph directly drains into the vein before the closure. Now I'd like to call upon Dr. Ashwin Emperor from the Department of Plastic Surgery to discuss the intraoperative challenges.
Good morning, everyone. Myself, Dr. Ashwin Cyril from Department of Plastic Surgery, Senior Resident 3. So, as you saw, after the lymphaticovenous anastomosis done under microscope, we check the patency of the anastomosis under the microscope. This test is called Ackland's test. So, this test is used to see the patency of the vessel post anastomosis. You milk the vein, you milk the anastomosis vessel post anastomosis, the distal anastomotic vessel. You just milk it, and you will just see the filling of the vessel from proximal to. After milking, you release the proximal clamp, and there is filling of it. So this is how you see the patency of microvascular anastomosis. And you can check the patency even through ICG, through infrared cameras. And the main intraoperative challenges you face in this are identifying suitable vessel, that is both lymphatics and the venous channel. If both doesn't match and there is a diameter disparity, you can implant the vessel. As you see here, you can implant the vessel with the perilymphatic fat into the associated venule, and you can take a suture all around. If it matches, you can go for intima to intima anastomosis. So the next issue is the fragility of the vessel. It is the lymphatic vessels and the venules are very fragile. If you just give a little tug, the whole vessel will tear off, and we cannot proceed with the anastomosis. And also pressure gradients. If the venous side has a higher pressure, there will be backflow into the lymphatic vessel, and it will get blocked, or there is no proper lymphaticovenous flow. And suture to vessel mismatch. As Dr. Prekshit said, the suture we use is 11-0-12-0, which is super microsurgery. But even using that, the lymphatic vessel will be smaller than that, so that we cannot use the suture 11-0-12-0 to suture the vessel, so that in those cases we cannot proceed with the surgery further. And coming to the post-operative management, there is no additional cost in post-operative management for the patient. The patient in immediate post-op should wear compression garments over the affected upper limb, and the patient should also take care of movement restriction. They should not abduct the shoulder more than 90 degree, and the patient should also not do heavy lifting or carry any heavy weights or doing any exercises. And from for short-term post-operative management, 3 to 12 weeks, the patient should initially start on shoulder mobility exercises, minimal intensity, then to maximum intensity to gain normal shoulder flexibility, and use compression garments only when they are doing strenuous work, and in normal time they don't want to use any compression garments. And manual lymphatic massage should be continued. Long term, the patient should watch for symptoms of lymphedema and objective measurements when the patient comes for regular follow-up in 3, 6 and 12 months. And patients should also take care of hygiene to prevent infection.
Thank you, Dr. Ashwin, and also the whole Department of Plastic Surgery to help us out with everything. So post this was the resected specimen. We can see the mammary tissue along with the intact pectoral fascia that comes out, the excised skin with the nipple areolar complex, the level 1 and level 2 lymph nodes, and the level 3 lymph nodes were sent separately. So post-operative course, it's routine like a normal patient for MRM. There is no change. There is no extra day the patient has to stay in the hospital. No extra medication that's needed. Post-operative day 0, they get mobilized. She was started on full enteral nutrition. Post-operative day 2, she was discharged with a drain. All sutures and drain were removed on post-operative day 14th. The final histopathological stage came out to be PT2N2. And the further treatment plan was formulated for adjuvant chemotherapy, post-mastectomy radiotherapy, and hormonal therapy. The patient is currently undergoing adjuvant chemotherapy and is doing well.
And no heparin or no dextran or all this?
We also don't require any kind of anticoagulants for this. So that sums up the case for today. I'd like to dive in a bit of review of literature for
We've
the
taken the help of physical and rehabilitation medicine for lymphatic massage and all those.
So we do take the help of
this case.
Not in this case currently, sir. We do send them for routine checkups during their follow-ups. If they're developing lymphedemas, they do give them compression therapy and if needed lymphopress. But currently for these patients, we've not needed.
So
Lymphopress we've not
This
needed.
is we have done per primum. So now post-operatively, all patients go for lymphopress,
PMS.
and physiotherapy, and all those things.
So this is very important, very
Yes.
specific.
Yes, sir.
We had labeled the lymphatics, two
Right.
clips. So,
Yeah.
might be a stupid question, but when do we consider doing a lympho to lympho anastomosis? We had double clipped the.
Yeah, so we've double clipped to check that if that is the lymphatic that's coming from the upper limb. Sometimes you can actually identify the lymphatic, but there are times that you
We
can't.
did a lymphovenous anastomosis. No?
We do a
And
lymphovenous anastomosis only.
Can we do a lympho anastomosis?
Not that we know of, for preventing breast cancer related lymphodemas. We don't do a lymphatic anastomosis.
And how many do we need to do? One is enough.
So sometimes if you get 2 or more lymphatics, so there are different patterns of lymphatic drainage from the upper limb. If it's a single wide channel, you can anastomose that to the vein. But there are times when it is a widespread pattern of drainage, so you can do 2 or 3, depending upon the size of the anastomosis that you've been able to capture. If it's draining well enough on the ICG, then 1 anastomosis is enough. But there are times when you can do 2 or 3 also.
What system you are using? What ICG system you are using?
We have the infrared system at the.
What is the name? Is it a handheld camera or is
No, we don't have a handheld camera currently in the institute.
We use an endoscope.
Yeah, we are using an endoscope for the same.
Thank you. Does the management of primary decides upon how the lymphatics drainage is going to, if we do a breast conservation or say modified radical,
Yeah.
it's going to be dependent on how we do the lymphatics, right?
Right. So this whole problem is about the axillary
Axillary.
nodal dissection.
Thank you.
The primary disease is
Doesn't
never
matter.
the problem. So either you're doing a BCS or you're doing a mastectomy, that remains the same. But if you're ending up doing an ALND or probably a level 3 dissection, so you do the upper limb lymphatic actually drains in the apical. You've taken them off, the more chances of lymphedema.
Thank you.
वैसे भी राम lymph to lymph vessel anastomosis is very very difficult. Ultimately all lymph they drain into the veins. So lymphovenous anastomosis probably to me seems better, like we do in radical hysterectomies.
This is what they showed.
So that's why we do an ICG
this is what they
confirmation.
showed. And that is was one of flow. No. They squeezed from one side and then released on the other side and saw that the flow was going from the lymphatics to the vein. So that has been checked. And all this is only for when you are doing a full axillary dissection. That is why this concept of sentinel node biopsy has come, low axillary dissection has come, or axillary sampling has come. In those things, we just take the that node, lowest node, send it for frozen section, and if that is negative, then we don't do it. So this is only for the complete axillary dissection that we have done.
There's also the rate for lymphedema with SLNB falls around somewhere between 5 to 10%. Great centers have gone down to even 4% of it. So that's where we don't justify doing an additional procedures for these people. But ALND still stands at somewhere around 35 to 40%. And most patients in Indian settings come with large lymph nodes. So we have to give them an axillary lymph nodal dissection. So they fall with increased lymphedemas.
And sir, the paper in Indian studies, they mentioned that the vein that should be preferred should not have a backflow, so that the anastomosis remains patent.
This problem is not there in head neck.
In?
I think this problem is not there.
Right. So moving forward, we'll dive a bit into the review of literature that we have regarding the procedure. So again, lymphedema, the unavoidable complication, the percentages we've discussed. The toll is 1 in 5 women will develop lymphedema post ALND. And currently, we have 1 million women living with breast cancer related lymphedemas. For them, we just have management treatments. So NCCN defines lymphedema as pathological accumulation of protein-rich lymphatic fluid in the interstitial tissue, causing chronic and progressive swelling. And it has a deep impact on life. There is a chronic arm swelling, there is restricted range of motion, Indian women can't do their household work, and like I showed in the cartoon, it becomes very difficult to open the pickle jar. Patient has recurrent cellulitis infections, there's anxiety, depression, there is body image distress. Second, the economical burden of it. Treating a breast cancer related lymphedema has a very high cost. Lifelong compression garment use, the patient requires repeated physiotherapy sessions, and definitely there is lost productivity and disability. So why lympha? Lympha means a lymphatic microsurgical preventive healing approach. It is a super microsurgical bypass that connects the arm lymphatics to venous tributaries before the closure of the patient, and it leads to immediate lymphatic drainage. So the vessel size stands somewhere around 0.3 to 0.8 mm, and the sutures we use is 9-0 to 11-0, and like sir pointed out, the human hair lies somewhere at 6-0 to 7-0. The added OR time is 30 to 45 minutes, and the patient needs to stay 0 extra minutes in the hospital after this. So the key clinical evidence comes from the landmark prospective study from Bocado done in 2009, where at 18, they followed up their 74 patients at 18 months. The patient who'd undergone lympha, 0% of them developed lymphedema. They followed them up for 4 years, and they found only 3 out of those 74 patients developed lymphedema, highest of grade 2 variant, which were managed conservatively. Next, we have recent data that comes from the meta-analysis of 1026 patients, including 28 studies, and they followed up their patient. They had a follow-up of 48 months, and they found the reduction in lymphedema rates from 41% to just 9.6% in patients going immediate lymphatic reconstructions. So we have another systematic review done in 2025 which confirmed a similar result. It also showed 69% lower odds of developing lymphedema, 58% reduction in lymphedema risk. We have a randomized control trial that came out of from Memorial Sloan Kettering in the US in 2023, which showed the lympha arm had 9.5% lymphedema rate versus 32% in the control arm. They also concluded that immediate lymphatic reconstruction decreased compression usage, better lymphatic function on ICG lymphography, and also better quality of life for the patients. Their 24-month follow-up report is currently awaited. We also have Indian evidence coming from Dr. Juhi Agarwal, who works at BLK Max. She happened to visit a center as well and give us a live demonstration of the procedure. So where does oncologically LVA stands? So there was a theoretical concern that anastomosing lymphatics to veins redirects the metastatic cells systemically, but the current evidence reported no cases of systemic dissemination that are attributable to LVA. The rationale being that rerouting residual lymph does not alter the primary tumor biology. So what happens to the quality of life? Lympha leads to an improved disability arm, shoulder and hand index, improved lymphedema related quality of life index, and SF36 scores at 12 and 34 months. The patency rate stands at around 65 to 90% at a year ending in experienced centers. Cost benefit analysis, like we discussed, there is a large sum of money that is saved from avoiding the lymphedema treatment once it develops. And the learning curve is relatively short, stands at around 20 to 30 cases. So there are some limitations and open questions that are going to be answered in the coming recent trials. The open questions being, what is the effect of radiation on the lymphovascular anastomosis that we've conducted? We have a Lympha-2 trial that is going to be soon reporting the results. They have a sub-study which is analyzing the effect of radiation on this. Another open question we have today is, what is the effect of neoadjuvant chemotherapy on the lymphatics and the feasibility of doing a lympha on that, which is going to be further addressed in the current ongoing trials. So where does lympha stand today in guidelines? The ISAMS, the International Society for Aesthetic Plastic Surgery, considers lympha as a valid preventive option where microsurgical expertise is available. ASCO 2024 said that there is emerging evidence which supports discussion of prophylactic LVA in all patients. And the American Society of Breast Surgeons, who are endorsing this procedure, they show that the lympha has promising results and should be considered in patients undergoing ALND where microsurgical expertise is available. So like we've discussed, we've come a far way from curing to giving the form and to giving function to the breast today. This is our center's experience. We started from 2022. The graph constantly goes up. The number of patients are increasing for breast. So we have a rising curve for MRM as well as for breast conservation surgery, but we can see a steep rise in patients now today opting for BCS, and we are able to give them breast conservation surgery thanks to a medical oncology department and to radiation who are actively treating our patients, taking our cases upfront on short durations at the tumor boards. Then we've moved on from giving patients axillary lymph nodal dissections, going towards a trend going towards sentinel lymph node biopsies, more conservative approach, and we soon plan to start with targeted axillary dissections. And like I said, thanks to plastic surgery department, we are now able to offer patients immediate reconstructions. We started from a single case in 2022. We've reached about 33 last year, and we've already crossed a mark of 14 by the quarter of this year.
Rajgovind, what is the progress in breast reconstruction? And Dr. Balwant was there from UK.
Most of our faculty is now trained in oncoplastic breast surgery. We have, they attend the workshops and they come and they are performing. So it could be a volume displacement or you can take a local thing or you can do a latissimus dorsi. As far as the pre-microvascular is concerned, then we do an abdominal testing, which is very difficult for a patient to accept. They say they'll require abdominal surgery and a mesh on the abdomen. They usually refuse. So now we are having better counseling, and now with joining of Dr. Naina, who will be doing the breast counseling, we hope that we'll have more and more breast reconstructions.
We, like Sir said, we just completed a DAP a week ago. So we completed a DAP just a week ago. So we have offered patients bilateral breast reconstructions, a single side breast, whole breast reconstruction with reduction mammoplasty on the other side. So the graph of breast conservation is actually increasing. So we've yet not done silicone based. We've only done autologous at a center currently. With implants basically. So some mesh for the abdominal side where we pick up the flap, but
yeah, sir,
yes, sir.
For that we don't require silicone, but silicone we need a biological mesh, which is quite expensive. Even the silicone itself is expensive, and then these patients have to undergo radiation. So sometimes there is a radiation reaction and then exclusion. So trying to convince the patient. It is not the availability of the facility, it is the patients who usually refuse these things. Yes.
Yes, sir. Plus, mostly immediate reconstructions we are able to do comfortably, but delayed reconstruction patients generally lose to follow up, or they've just given up that they don't want to go for a reconstruction or any other additional procedures. Silicon generally we use for a delayed reconstruction, so acceptance to that is a little difficult.
It is less here, but in metropolis cities or in the higher societies.
Sir, in the West, now there is a movement towards going flat movement. They say that through a mastectomy, no radiation required, no reconstruction required, one-time surgery and go home. This is what they are saying.
So, sir, as sir explained, in all the patients we are seeing, we have all the instruments, the armamentarium to do the reconstruction, conservation surgery. Right now the problem we are facing is convincing the family that it will not lead to recurrence or it will not increase their chances. Otherwise we are all equipped, well equipped to do implants, everything. We recently did a whole breast reconstruction with the plastic surgery team, and it went very well, touch wood. So we have everything. Right now we're just learning techniques, how to convince the family and the relatives that it's okay.
So far now we've completed about 12 prophylactic lymphaticovenous anastomosis. We've also completed 8 vascularized lymph node transfers for patients who've already developed lymphedema, and all patients are currently doing well and are on regular follow-up. We are also aiming towards higher numbers. Thank you. That's from my side. I'd like to call upon Dr. Rahul Khubchandani sir to take the closing statement.
Good morning, everybody. Thank you, Prekshit. And regards to senior faculties and management, I am Dr. Rahul Khubchandani, and I would like to summarize the case that we have presented. So where we are today in the management of breast cancer patients, we from a surgical point of view, from a medical oncology point of view, from a radiation oncology point of view, we are in the era of de-escalation. From Halstadian radical mastectomies in 1900s to modified radical mastectomies in breast conservation surgeries with radiotherapy since early 2000, now to oncoplastic breast reconstruction. From comprehensive axillary lymph node dissections to sentinel lymph node, and now to avoiding axillary management altogether. Even post-operative adjuvant treatment in the form of radiotherapy and chemotherapy can be avoided in certain cases. So why we need the fourth component of the surgery? In India, modified radical mastectomies in surgical modalities still dominates due to a variety of reasons: late presentation, social factors, resource constraints, increased burden of lymphedema. Even with all modern medicines and techniques, axillary lymph node dissection is unavoidable even today. And as Benjamin Franklin said, an ounce of prevention is better than a pound of cure. Is it safe? Yes. It takes only 45 minutes, reduces the lymphedema rates by 20%, and cost effective. Should be discussed with all ALNA patients at institutions with microsurgical expertise. Thank you. Now I would like to give my regards to the patient, her family for their trust and faith in the institution, senior management, hospital administration for providing us with all the facilities for optimal diagnosis and treatment, CCR review committee, departments of plastic surgery, medical oncology, radiation oncology, oncopathology, nuclear medicine, anesthesiology, pain and palliative medicine, psycho-oncology, physical medicine and rehabilitation, and physiotherapy. Thank you.